Welcome. We are Wim and Axel. We hereby present our scientific article to obtain the title of Bachelor in Osteopathy at the International Academy of Osteopathy. The title of this scientific article is as follows. Will the same thoracic limited range of motion and/or neurovascular changes be found with the diagnosis of somatic dysfunction? Interreliability of manual diagnostic tests versus themographic imaging. The structure of the presentation is as follows. We will start with an introduction. In materials and methods, we will discuss how the testing procedures were conducted. Then the objective and hypothesis of this scientific article will be presented. And via the results and discussion, we will give an overall conclusion and provide guidelines for further research. Introduction. Somatic dysfunction, also known as an osteopathic lesion, was first defined by Ira Romney in 1973 as an impaired or altered function of related components of the somatic system, skeletal, arthrodial, and myofascial structures, and related vascular, lymphatic, and neural elements. Structural problems such as bone fractures or inflammations do not qualify as somatic dysfunction. Therefore, Fred Mitchell made an important addition to the concept of somatic dysfunction. Manipulation is an appropriate, effective, and sufficient treatment for it. STAR is an acronym for 4 diagnostic criteria to determine somatic dysfunction. It includes sensitivity changes, changes in the tissue texture or structure, asymmetry, and reduction of the range of motion. Because treatment of somatic dysfunction in the spine is an inherent part of an osteopathic treatment, it's important that the tests to find the STAR characteristics are reliable. According to the literature, evaluation of individual STAR characteristics showed poor agreement. Evaluation of sensitivity and more specific pain palpation was most reliable, showing a moderate agreement. In the study of Stockendal et al., it was shown that combination of diagnostic tests to find STAR characteristics improved reliability. The use of infrared tomography to find changes in the tissue texture or structure, and more specific and altered skin temperature, showed good intra- and interreliability to determine tissue or texture changes. Material and methods. The neural therm scanner of the inside subluxation station was used to measure the right-left paraspinal skin temperature difference of the segments T1 till T12. An output file of the scanner is showed. Skin temperature differentials are shown as a colored bar on the computer screen. The color of the bar is determined by the magnitude of difference. A right-left paraspinal skin temperature difference above or equal to 0.54 degrees Celsius was counted in as a significant increase of sympathetic activity. The procedure of the manual tests are explained in the following video. The procedure of manual testing consisted of 3 manual tests. First, the examiner palpated the spinous process of T1 till T12 with his thumb and index finger for sensitivity. If the palpation was sensitive, the spinous process was marked. Secondly, the first motion test was performed. The examiner placed the lateral side of the thumb on the lateral side of the spinous processes of the segments. With the other hand and arm, he initiated an oscillation movement through the spine of the patient in a frontal plane. From T1 till T4, the oscillation was initiated via the head of the patient. From T5 till T12, the oscillation was initiated via the shoulders of the patient. The examiner felt for joint play with the tip of his thumb. The segment could be felt as free or not free. When a segment was diagnosed as not free, a second motion test was performed. The examiner placed the lateral side of the thumb on the lateral side between 2 spinous processes. The patient was moved into side bending and rotation. When palpating the underlying spinous process, the examiner checked the movement of the upper spinous process. Objective. The main objective of this study was the evaluation of the interreliability of diagnosing somatic dysfunction in the thoracic spine using manual tests and infrared tomography. The following hypotheses were formulated. There is a high correlation between the determination of somatic dysfunction with infrared tomography and manual tests. Secondly, there is a higher correlation in the determination of somatic dysfunction with infrared tomography and manual tests in subjects with a body mass index below 25, in subjects with a higher score on the Quebec Back Pain Disability Scale, and in subjects that study osteopathic medicine in comparison with subjects that don't study osteopathic medicine. Results. A kappa analysis was performed to investigate if the same segments with somatic dysfunction were found with infrared tomography and manual tests. The interreliability showed a poor agreement. When lowering the cutoff to 0.37 degrees Celsius, excluding the patient with a body mass index higher than 25, excluding the subjects that didn't have knowledge of the testing procedure, or performing the kappa analysis with only the male or female subjects didn't significantly influence the kappa value. Secondly, the mean paraspinal right-left skin temperature difference measured with infrared tomography as a function of the manual examination of the thoracic segments was compared. Therefore, an independent sample t-test was used. Results showed there isn't a relation between the mean paraspinal right-left skin temperature difference and if a segment was manually diagnosed as free or not free. When performing an independent sample t-test of the individual segments, the following results were found. T2 and T3 showed a higher paraspinal right-left skin temperature difference if the segment was manually diagnosed as free, while in T4, T5 and T12, a higher right-left skin temperature difference was found in the segment that was not free.
Discussion. The poor interreliability of the determination of somatic dysfunction in the thoracic spine between infrared thermography and manual tests is possibly due to limitations of the thermographic device. The intrinsic factors of the subjects were controlled. Because the age of the subjects was relatively constant and gender was equally distributed. Environmental factors were difficult to control. An ambient temperature of 21 degrees Celsius is stated to be the perfect ambient temperature for infrared thermography. However, in this study, the ambient temperature fluctuated between 18 and 25 degrees Celsius. An acclimatization period of 8 minutes is recommended to obtain reliable thermal data. This factor could not be met due to infrastructural limitations. Experience of the investigators could possibly contribute to the poor interreliability. In the study of McCoy et al., intraclass correlation coefficients of 0.959 to 0.976 for paraspinal thermal scanning were found. In this study, the intraclass correlation coefficient was 0.708. This is showed in the graph on the right side of the PowerPoint presentation. Finally, the question remains, what's the validity of the thermographic device? Is the altered skin temperature caused by a somatic dysfunction or possibly something else? For example, trauma, inflammation, etc. The poor interreliability for determining somatic dysfunction with infrared thermography and manual tests could also be caused by several limitations of manual testing. First, the reliability of an individual test to find star characteristics is poor. Therefore, in this study, both sensitivity palpation and mobility tests were used. This according to the study of Stockendahl et al. A combination of tests to determine the star characteristics increases the reliability to diagnose somatic dysfunction. A second influence factor is experience. Haak et al. Showed that the intra-reliability for diagnosing somatic dysfunction with manual tests increased with experience. Third, the question remains, what's the validity of manual testing? Is the altered sensitivity and mobility of the thoracic spine effectively caused by somatic dysfunction? Secondly, the relation between skin temperature and the manual investigation of the thoracic spine was searched. A segment at the level of T2 and T3 that was free showed a higher mean paraspinal right-left skin temperature compared with the segment that was not free. For T4, T5 and T12, an inverse temperature relation was found. The reason why these results have been found could have had multiple causes. First, with the presence of a somatic dysfunction, mainly the sympathetic part of the autonomic nervous system is stimulated. Most blood vessels are innervated by sympathetic nerve fibers. These nerve fibers induce vasoconstriction, through which skin temperature is decreased. In the study of Snyder et al., it was shown that chronic low back pain patients have a greater incidence of star characteristics compared with asymptomatic patients. This would indicate that somatic dysfunction is more present in low back pain patients. Furthermore, in the study of Roy et al., it was shown that manipulative treatment increased skin temperature in patients with chronic low back pain. Combining these two studies, this would indicate that manipulative treatment of a spinal segment decreases the sympathetic nerve activity, through which skin temperature is decreased. This would indicate that manipulative treatment reduces the incidence of somatic dysfunction. Secondly, why a free segment at the level of T4 and T5 showed a lower mean paraspinal skin temperature difference compared with the segment that was not free is possibly due to the period somatic dysfunction is present. When there's an acute somatic dysfunction, there's also a mechanical dysfunction. Mechanical dysfunction leads to inflammation, through which skin temperature is increased. With a chronic somatic dysfunction, the same neurophysiological pathways are stimulated, leading to a decreased skin temperature. So summarizing, acute somatic dysfunction leads to an increased skin temperature, chronic somatic dysfunction leads to a decreased skin temperature. A third reason why the relation between the manual investigation of the upper thoracic spine and skin temperature was found is possibly due to the visceral segmental sympathetic nerve supply. Mainly heart and lungs are innervated via T1 until T5. Possibly, there is an increased facilitation of these segments caused by the viscera. Nevertheless, for a segment at the level of T2 and T3, a decreased skin temperature was found, and for a segment at the level of T4 and T5, an increased skin temperature was found. This can be explained as follows. Excitation of viscera leads to an increased segmental facilitation. The sympathetic nerve activity is increased. On one hand, temperature would decrease. On the other hand, these segments would be more vulnerable to suffer from an acute somatic dysfunction. This would lead to an increased skin temperature. Conclusion. This research confirmed what other studies found. The interreliability for diagnosing somatic dysfunction is poor. This is probably caused by a weak understanding of the pathophysiology of somatic dysfunction in its current form. Before further reliability studies are being performed, the concept of somatic dysfunction has to be clarified for all osteopaths. This will lead to a better communication between osteopaths and between osteopaths and therapeutics of other medical professions. In the study of Fryer et al., a new model is suggested where the influence of nociception is crucial. This model can form the basis to clarify the concept of somatic dysfunction and provide a better understanding in the pathophysiology. Our call to the osteopathic schools and the osteopathic society is to work together in clarifying and unifying the concept of somatic dysfunction. So, thank you for your attention. If there are any questions remaining, the complete information is to be found in the scientific article.